Yeah, well, thank you very much, Naren. It's great to see you, and I'm delighted to share the podium today with my good friends and colleagues, Saadi and George. And I'll just be speaking today about hemispherectomy. It's a topic that over the years I have come to enjoy from many perspectives in terms of the surgery and all sorts of aspects of this particular condition. But first, Naren, I want to thank you for all that you've done over the years for neurosurgical education worldwide, because with your webinars, especially at challenging times in the world, like during the pandemic and before that time, you were among the first to utilize electronic and digital communications with the neurosurgery world, and for that we are truly grateful to you. I understand there are something like 90 countries online today, so welcome everybody, and we'll proceed with talking a little bit about hemispherectomy. The history is very interesting. So Dandy performed hemispherectomy in patients who had malignant gliomas, thinking that before they were to transfer to the contralateral side, if you removed the diseased hemisphere, then you could make those patients free of tumor. Of course, that proved not to be true. Mackenzie, who's a University of Toronto, he's the first chair of neurosurgery in Toronto. He performed the first hemispherectomy for epilepsy, and that patient did extremely well after the hemispherectomy. Rasmussen in 1970 devised functional hemispherectomy. Villemure described the peri-insular hemispherotomy. That's a technique that many of us have used over the years, and I use a modification of that procedure. Carson described hemidecortication. We've done that previously at the University of Toronto. Delalande in 2007 describes vertical parasagittal hemispherotomy. And then most recently in advance has been Chandra's description of robotic hemispherotomy, which I'll describe at the end of this presentation. So there's Harvey Cushing, the so-called grandfather of neurosurgery, and standing next to him is K.G. Mackenzie, the gentleman who performed the first hemispherectomy in Toronto at the University of Toronto, who trained with Cushing in the 1920s before coming back to Toronto and starting the first program of neurosurgery in Canada at the University of Toronto in 1924. So we just 1924. So we just celebrated, it turns out, our 100th anniversary for the University of Toronto in neurosurgery. These are the main conditions for which hemispherectomy is applied. So Rasmussen, Sturge-Weber, perimiddle cerebral artery infarction, hemimegalencephaly, cortical dysplasia, and polymicrogyria. So if you remember this list, then what you'll do is you'll be able to score 90% of all cases in which hemispherotomy is required. There's some other examples of diseases, and I'll talk about those in a moment. But for those conditions I mentioned, these are some of the imaging features. So hemimegalencephaly, very disturbed hemisphere. Sturge-Weber, the typical tram track appearance with the affectation of the hemisphere, and you can see the atrophy that takes place. Rasmussen encephalitis, where you also have atrophy without the enhancement, and here holohemispheric cortical dysplasia. And in the days when anatomic hemispherectomies were performed, this would be an example of what a hemisphere would look like after an anatomic hemispherectomy. There are some less common indications for hemispherectomy, and I'm listing them here, and I've operated on children who've had all of these syndromes and also neurosurgical conditions. And so these are more rare, but on occasion, the repertoire of conditions for which hemispherectomy is indicated expands, and these are some of those situations. So what do you need to know? If you're doing hemispherectomy, you should study in advance on your MRI scan the ventricular size, the Sylvian fissure, where is the circular sulcus, location of certain landmarks, thickness of the corpus callosum, understand the surface anatomy. If there is parenchymal atrophy, that's a favorable situation. And if there's abnormal vasculature, you should have your eyes open for these alterations because they will affect the way in which a hemispherectomy is performed. What's the optimal timing of surgery? Usually, this is best in children under age 2. After the sixth to eighth year, of course, the dominant hemisphere is developing. And so, if you have a requirement to do hemispherectomy on the dominant hemisphere side after age 6 or so, what happens to language is still unclear. So, this supports earlier surgery in pretty much all cases. And there's higher success the shorter the time is between the seizure onset and surgery. And early seizure control allows for optimized psychosocial development. And I've done hemispherectomy as young as 2 months of age. Over the course of time, we've gone from maximal neurosurgical procedures and removal of tissue to more minimal forms of disconnections and tissue removal. So from anatomic hemispherectomy all the way down to central vertical hemispherotomy, maximally invasive down to minimally invasive over the course of the last 50 years or so. We did a comparison of two techniques, so perinsular hemispherotomy versus hemidecortication, and the hemispherotomy is typically better tolerated, especially in the young child, less requirements for blood transfusion, less incidence of CSF shunting. And for hemidecortication, there was definitely a higher incidence of shunting and challenges at times knowing how much of the neocortex to remove. An example of perinsular hemispherotomy, and here's an example of hemidecortication at the time of completion of surgery. And we published this in Neurosurgery a while back, comparison of our two techniques. But since that time, we've moved almost exclusively to perinsular hemispherotomy, although we're moving towards doing the vertical hemispherotomy. But it's a radical hemispheric tractotomy. And so there are various steps involved in hemispherotomy: a suprainsular window, infrainsular window, temporal lobectomy, corona radiata transection, corpus callosotomy, frontal basal disconnection, and insular resection. And pretty much you proceed in that order. It can be plus or minus depending on the anatomy you're facing, but generally speaking, these are the steps involved in hemispherotomy. So for the insular windows, you'll recall the suprainsular window and the infrainsular window. Here's the insular cortex, so peri-insular hemispherotomy. And a very important landmark is the corpus callosum, and located here, which you'll be finding. And you do a corticectomy of these windows, of the supra and insular windows. So removing the temporal lobe, you don't have to do a temporal lobectomy for hemispherectomy. I have done it, and in fact, Vilmur, who described the technique at first, said temporal lobectomy was not necessary as long as you disconnected the mesial structures, especially the fornix, and you do a hippocampectomy. But he faced some challenges with venous congestion of the temporal lobe and had to go back at times to take out the temporal lobe because of the venous congestion. So by and large, now several groups, and mine included, we do temporal lobectomy, including mesial structures, and that comprises the infra-insular window. And here's some of the anatomy that you can see of the temporal lobe, and then the trigone of the ventricle and the choroid plexus in the ventricular system. The corona radiata transection, this is really going across the corticospinal tract. So once you're in the lateral ventricle, the corona radiata, can be transected from the temporal horn to the trigone and then anterior to the extent of the frontal horn. So you're in the trigone here, you go temporal horn to the trigone, which is here, and then forward towards the frontal horn, and you disconnect and you undercut the corona radiata as you do this procedure. Then there's the callosotomy. This is after the temporal lobe and the mesial structures. And I have a brief video here, but this is probably where this blue dot is likely the location in which I find the pericallosal vessels from within the ventricle. So it's about a centimeter above the foramen of Monro here, up in this direction, and then you're aiming superiorly so as to come across the corpus callosum. The patient's in a lateral position, And this is the video that shows this corpus callosotomy as you're within the ventricle. So unlike a callosotomy that is done from above, interhemispheric, this is from within the ventricle. So it's kind of curious that now you're seeing the pericallosal vessels from within the opened ventricle. So we're about a centimeter above the foramen of Monro, which was there, and now we're finding the pericallosal vessels from within the ventricle. You can see that. I'm just speeding the video along, and we're going anteriorly towards the genu of the corpus callosum, towards the rostrum, and now we're going posteriorly, and you can see the interhemispheric space here as we go as far back as we can on the opening of the callosotomy, doing the body, the genu, the rostrum, towards the splenium. And then there'll be other steps involved. There's a posterior disconnection step, and here it is in the yellow on this anatomical sagittal image. So we've left off with our callosotomy in the previous slide, previous video about here, and now we'll pick up with the disconnection of the hemisphere by following the falx down to the tentorium like this and following it out into the temporal lobe. Here's a video of the posterior disconnection. And so what you're seeing, this is the free edge of the tentorium here. The falx is up here. So falx becoming the tentorium. And then we're going to follow this all the way through until we get into the temporal horn. And we've disconnected essentially the posterior structures by following the tentorial edge all the way out. And you come across the calcar avus. You're just behind the tail of the hippocampus and the fornix at this stage. And already you've done a very extensive hippocampectomy, so everything should be disconnected posteriorly with this hemispherectomy. And then finally, there's the removal of the insula, and there's also frontal basal, which I'll get to, but the insular resection you can do it one of two ways. One is going in between the penetrating vessels, the arterioles of the insula, which is a very good technique and sometimes the only technique to use, or sometimes you can do this on block elevation technique. And I'll show this in the context of a child who has Sturge-Weber, and you'll see the discoloration of the insular cortex here, where my arrow is pointing, and we're lifting up the insular cortex, having undercut it. Now, here's the ventricle that we're in, and we've undercut the entire insular cortex, lifting it up. Remember, the insular cortex is only about 3 millimeters thick compared to the regular cortex, and this is one way to do on-block resection of the insula. But as I said, sometimes you have to go in between the penetrating arteries of the insula and just shave down the insular cortex so as to achieve an insular resection. Seizure outcomes after surgery for anatomical hemispherectomy, about 80 to 90% good seizure control. It's a little bit better for peri-insular hemispherotomy, and better outcomes are observed in the context of Sturge-Weber, Rasmussen, perimiddle cerebral artery infarction syndrome. Some complications arise after hemispherectomy, including with anatomical, slightly higher mortality rates, CSF leak, wound infections, and the like. Sinus thrombosis is also quite possible to happen with anatomical hemispherectomy. For peri-insular, lower mortality in general, less blood loss, less incidence of CSF shunting, and this condition, superficial siderosis, is almost never seen in peri-insular hemispherotomy, and probably its incidence is quite low even in anatomical, but it has been reported. So in the last 2 years, you can just take a note of this article we published over 35 years, and there's no question as you do this procedure over many decades, your experience improves, and you also get better outcomes given the complexity of the surgery. Now I'm sharing the load of the hemispherectomies at Sick Kids with Dr. George Ibrahim, who's outstanding epilepsy and functional neurosurgeon. You can see that our hemispherectomy numbers have increased over time and the age at which we've been doing it slightly increasing over time. But again, the take-home message is the earlier you do hemispherectomy, the better. The indications for hemispherectomy prior to 2013 were these. So Hemi-Meg, Rasmussen, cortical dysplasia, Sturge-Weber, and stroke. But after 2013, we had a higher incidence of patients with the middle cerebral artery infarction syndrome, polymicrogyria, and hemimeg, and so on. So a slight difference over these decades in the etiology for the hemispherectomy. In terms of seizure outcome, seizure recurrence predicting was better as you had more experience, and then certainly seizure freedom became better over time. The results are probably not here statistically significant, but over time, just generally speaking, as you do this particular procedure over the course of many, many years, your results get better. And here, proportion of patients achieving seizure freedom, just gradually increasing short-term and long-term, and the number of patients with complications decreasing over time, just demonstrating an experience that is garnered over the course of time with a complex procedure like this. These are some of the complications that will arise following hemispherectomy in patients with the periinsular hemispherotomy technique. So incidence of hydrocephalus, less than 10%, probably on the order of 5%, and then some of the others. So very well tolerated, and very few, catastrophic side effects from this procedure. So case one, just a couple of illustrations. A 2.5-year-old, sorry, 2.5 months. So 2.5 months, female with seizures starting first week of life. MRI demonstrated left occipital cortical dysplasia that you can see over here. Just couldn't stop the seizures. Infantile spasms developed, and this was kind of an emergency situation where the neurology team asked us to do surgery at this very young age, pointing out there where the abnormality is on the MRI scan. It's typically quite extensive, involving multiple lobes. Surgery was done in about 5 hours, spent about a week in hospital afterwards. The hemiparesis was slightly worsened but recovered to baseline after the surgery. Angle 1 now, many years after surgery. There's on the initial post-op CT, the frontal cut, the occipital disconnection cut that you can see. The callosotomy is also visualized there. There's the callosotomy. There's the frontal disconnection. Here's the partial removal of the temporal lobe, and the mesial structures have been removed. And this child has done extraordinarily well, as mentioned. So we've learned over the years that you can use functional mapping, but more importantly, for this condition, you can do this with infants as young as 2 months of age. But there are some technical considerations and complications. So Saadi and also George know that operating on a 2-month-old and a 1-month-old is challenging. And if you're doing an extensive procedure like this, the post-operative scans look like this. So they're quite obvious that the brain is very soft, and you have to really know your anatomy and your landmarks in order to do this successfully. But this was a case of hemimegalencephaly in a very young infant, and we did the hemispherectomy, and this is what it looked like in the long term. You can see the disconnection front and back. The callosotomy has been performed, and this child has become seizure-free. And so you can rescue these children, make them seizure-free, despite the fact that many of them are in a state of catastrophe with their seizures at a very young age. So you can rescue those children. So here's another one, case 2, 18-month-old boy with transposition great arteries, heart surgery at a very young age, had a left middle cerebral artery infarct, intractable seizure since age 8 months, using left side, some right-sided movement, right arm is flexed at the elbow, standing with assistance and vocalizing, so 18 months of age at initial surgery. There's the stroke that you can see. And here's before and after the surgery, having done a periinsular hemispherotomy and opening essentially along the Sylvian fissure. And this operation was about 3.5 hours, 1 week stay in hospital, no change in neurological status, seizure-free at 5 years. And here's the immediate post-op CT scan looking like this, with frontal and posterior disconnections having been performed. Diffusion tractography, so DTI is a technique for tracing white matter pathways, and we've used DTI just to examine whether there are any residual connections in any of the work that we've done. Here's where, after a hemispherotomy, we found a small residual bundle going across the corpus callosum by functional MRI. Here you can see it in the basal part of like the rostrum of the corpus callosum, which is often where you might have a persistent connection. So we've used DTI to help us identify this. And if you do surgery in these cases, it's like a 15, 20-minute operation with navigation to find where this small connection might be left. And on this video, to disconnect this very small connection. And then these children can be rendered seizure-free again. And this is worth doing even, 5 or 10 years after the initial hemispherotomy if they have a seizure recurrence. We've also used MEG for hemispherectomy, and here you're seeing the advantage of MEG. If you have a unilateral cluster where the hemisphere is abnormal, that predicts better for seizure outcome than if you have bilateral clustering, which is shown here, where the outcomes are not quite so good. And of course, this is important for those centers that have MEG. It's still a very expensive technology, but we published our results with MEG in hemispherectomy. I just want to show you some outcomes in children who have had hemispherotomy. And this is a child 1 week after hemispherotomy, getting up and walking after a functional hemispherotomy, as shown here, climbing stairs 1 week after surgery, which is, I think, the fastest return to function that we have seen, obviously with the hemiparesis, but proceeding very well 1 week after surgery. And here, many years later, skiing. This is the same child after hemispherotomy, skiing here in Canada, of course, a great sport. And here, scuba diving, here again on water skis, and then here, snowboarding. So our waterboarding, you can see the hemiparesis on the left arm, but amazing. This was a child with Rasmussen encephalitis who had a fantastic outcome. So what have I learned after 35 years? These are some, I would say, pearls that I can pass on to you. Begin with temporal and frontal opercular resections. Find the pericallosals within the ventricle early. Sharply divide the ependymal veins. As you're in the ventricle and you're cutting across the pericallosal vessels, there are all these ependymal veins. You want to make sure you cut those sharply after you coagulate them. The falx is your friend. You're following it to the free edge of the tentorium so as to do the posterior disconnection, preserve all branches of the posterior cerebral artery over the tentorium. And there are different strategies, as mentioned, for resecting the insular cortex, but be aware of venous drainage anomalies in Sturge-Weber. And here's an example in Sturge-Weber. The entire ventricular system, lateral or even central, can be filled with these huge venous channels. And that may be a contraindication for doing periinsular hemispherotomy in the ventricle if you've got all these venous anomalies within the ventricular system. There's subtotal hemispherectomy now, where you preserve this. Here's the central sulcus. You do a frontal and posterior disconnection, preserving the central sulcus. And I've done this on a few occasions. It's technically a demanding procedure, but it preserves function. And I don't think the seizure outcome yet has proven to be as durable as in hemispherectomy for sure. So we need more data on this. And then this is a vertical parasagittal hemispherectomy. You can see the cuts here. Case shared with me by Thomas Czech in Vienna, different technique. And then finally, the robotic thermocoagulative hemispherotomy by Sarit Chandra, where he has disconnected the entire hemisphere using radiofrequency ablation. Great technique, likely to be advanced over time. And think about minimally invasive approaches. This is it. So stay tuned to some more advances for thermocoagulative hemispherotomy. For those interested, here's some further reading that you can do. Some of these I've already alluded to in my presentation today, but this is an experience garnered now over 35 years. I was very happy to share this with you, and I'd be very happy to take any questions that you may have. So thank you for your attention, and thank you, Naren, for the invitation. I'll stop sharing and be happy to answer any questions.
Thank you very much, Dr. Rutka, for this excellent lecture, which I understood, even though I'm not an epilepsy surgeon, of a very complex operation. I just want to first of all ask our faculty whether they have any comments or questions. Dr. Jallo, do you have any comments or questions for Dr. Rutka? Thank you.
Naren, thank you. Jim, that was an excellent presentation. I think, if this is a demanding operation, as we all know, and you've simplified it so well and so eloquently for the participants. I think it's critical that if you're going to pursue this path of doing a hemispherectomy in a child, that you understand the anatomy and follow the steps that you have outlined. Because, as you said, you can get lost in there, and an incomplete disconnection will result in the return of the seizure. So I think it was just wonderfully said. So thank you for sharing your 35 years of experience with this technique. Jim, one question. The Baltimore group at Hopkins, we published a paper using endovascular disconnections.
Yeah.
I've got mixed feelings about it. So I'm wondering your thoughts. You shared Chandra's paper about the thermal ablation for hemispherectomy. The other technique that we were doing is the endovascular occlusion of the vessels in a staged approach, more of a minimally invasive. I mean, do you think that's the future, or we're still going to be doing open surgery for these?
Yeah, thanks very much, George. Yeah, just to comment on your first point, and yeah, if you're going to do this procedure to everybody online, practice if you have the option to go to either an anatomy lab to do the steps step by step that will prepare you for this. Go somewhere where they're doing these cases so you can actually see them firsthand and look at the steps that are involved. This session is going to be recorded so you can look at the steps that I've already outlined for you. But you need to practice. And there's also now a simulated hemispherotomy model that we published on from sick kids. So there are many teaching tools to help you with this strategy. So learn those. Try to get a senior person helping you with your very first case if you're just starting your practice. And that way you'll be able to build your experience and help your patients best as possible. And if you have recurrence, because of incomplete disconnection, that's not the end of the world. You can always go back, but you really have to study where the incomplete disconnection was made and then go back to that focal site. And these patients can be rendered seizure-free over time. Now, as far as the endovascular, George, that's a great question. And we did our first about a year ago. We hadn't done it before, but based on the paper, from Hopkins, we decided to do one, and it worked well in a very young infant, 3 months of age, who had not only tuberous sclerosis, affecting both hemispheres, but had hemimegalencephaly on one hemisphere. So very curious, and we thought, you know what? In this case, surgery is pretty morbid, and the outcome for this child is unknown at age 1 or 2 months. So we did on the affected hemisphere, the hemimeg side, we did an endovascular, and it worked great. We had to stage it over like a month and a half, doing one like the anterior cerebral, then middle cerebral, then posterior cerebral artery blockades. But after that, this child did remarkably well, and seizure is not while seizure free, but has markedly improved in seizure control. So I think it's a back pocket strategy that you can use, and it may become even more interesting over the course of time. It requires a lot of resourcing, and you can't do it all at once. Typically, you usually stage it, but something to consider, George. So thanks for bringing that up.
Thank you, Dr. Jallo. Dr. Saadi Ghatan, your comments and questions for Dr. Rutka. Thank you.
Yes, excellent lecture and great comments, guys. I think that we've always got to search for a less invasive way of getting it done. I think that a critical point that you made, Jim, that I want the audience to really take to heart is the sometimes very rapid, but ultimately very satisfying recovery that these children make, which is critical to know and take to heart with the families. This represents the most invasive conceptual intervention one can take in neurosurgery, really, disconnecting half a hemisphere, removing half a hemisphere historically. And while it may look less invasive to do a periinsular functional hemispherectomy, it still represents a disconnection of half of that child's brain. And yet they do better when you do that. And that is critical to take home to the families and your referring neurologist, because that level of invasiveness is often lost on those who are thinking about doing it. It's very important to remember these kids make a great recovery in the vast majority of these cases.
Yeah, thanks, Saadi. Some of my best patients in my entire practice in 35 years are the kids on whom I've operated with hemispherectomy. They have a life. I mean, they had no life going into, coming into the world, but seriously, many are fabulously well, obviously with deficit, but without seizures, like seizure-free, off medication, normal schools. The child I showed you who was skiing is off, graduated from university, is now fully employed. I mean, amazing outcomes. Are they all like that? No, I'm can't say because some children are very devastated going into the hemispherectomy with global developmental delay, etc. But you can very much impact on their seizure control, which offers them, I think parents would all agree, a better quality of life.
Thank you. Dr. Rutka, thank you very much, Dr. Ghatan. Dr. Rutka, there are a couple of questions that I will read out. First of all, from Dr. Shoaib, I think you touched on it that this lecture is recorded, so you can go through the step-by-step of how you do your peri-insular hemispherectomy. But the question is that I think the broader question is that you have got a lot of skull-based courses, a lot of spine courses. I don't come across so many epilepsy surgery courses, but I do come across many epilepsy surgeons who do struggle with hemispherectomy. And also, could you elaborate on the virtual simulation or the simulation system that you and your colleagues developed? Thank you, sir.
Yeah, thanks. So we teach an epilepsy course. I think Cleveland Clinic has an epilepsy course where procedures like hemispherectomy are instructed. So those of you online, if you're wanting to get into this realm of surgery, you can write to me and I can let you know when some of our next courses are being given to our residents, but it's at least once or twice a year. And these are great, these epilepsy courses, not only hemispherectomy, but open callosotomy, lobectomies, deep brain stimulation, electrode insertion. We're doing everything to teach this. And same thing with Cleveland Clinic and multiple other courses that are available. That simulated model, Naren, is online, Journal of Neurosurgery. And Grace Tiango was a PhD fellow working in Dr. Drake's in my laboratory, and she developed a model. It's a simulated model for hemispherectomy. You make a model and you follow the steps, and there are key landmarks found as you complete each step within the simulated model. So I would refer the readers just do a search under Rutka and simulation and hemispherectomy, and you'll find the paper.
That's brilliant. Thank you so much. That's very good to know. There's a question from Dr. Dirk van Roost. His question is the anterior commissure generally interrupted during peri-insular hemispherectomy?
Yeah, thanks. Great question. The answer is yeah, not
Hemispherectomy.
routinely. As you know, the temporal lobe has a bundle leading from it that goes across the anterior commissure. So if you do a complete anterior like a temporal lobectomy and mesial structures, there should be no need to do commissurotomy. However, that being said, in patients I've had who have failed, and I've done a complete disconnection to my eyes, and the only thing that I can see is that the anterior commissure is intact. I'll sometimes go in endoscopically and do a commissurotomy endoscopically, to see. And then that's helped in some of my cases for sure. It's a minimally invasive approach, but it's one that you would do after you very carefully study your post-op um, MRI scan and make a good case for that's where the seizures seem to be coming from. Still something left either within or around anterior or temporal lobe areas, and then a commissurotomy can be done. I haven't done a posterior commissurotomy often, although I have done it. But anterior commissure is quite easily targetable and may be the source if you've left a few aspects of the temporal lobe in situ.
Jim, I remember Vilmuir's group publishing about this, and always take it to heart when I've done them because I recognize that was a source of failure.
That's right. Yeah, so it can be, and I don't do it up front, but it's something I would come back to if I have a failure, and it could be a failure after 5 or 7 years, and it's a very simple procedure to do because typically the ventricle is very expanded on that side, and you can target the commissure with navigation and the endoscope or an open approach.
Thank you, Dr. Rutka. Just a question from me. Has the hemisphere that has been disconnected, has that been studied as to what happens in terms of its, is there a second brain that is pretty much muted? Is it still trying to function? Do we know what happens to that isolated hemisphere?
Well, yes, what's curious is that isolated hemisphere that you've operated on continues to have interictal epileptiform discharges. So, but those discharges are disconnected. They're not going anything. They're not achieving any function. And progressively over time, you're seeing atrophy and you're seeing shift of the brain to the side that was operated upon. And the Sylvian fissure, if you study Sylvian fissure, tilts down. So a lot of changes occur on the operative side. But in terms of the functional analysis, very little has been done to really characterize what's going on intrinsically within the operative side of the brain. But we do know that if you do EEG, don't get disturbed, that you see all this seizure activity. On MEG, you see all these MEG spikes on the affected side because it's still seizing, but you've disconnected it from talking to the other side of the brain or going anywhere in terms of seizure activity.
Thank you. Thank you so much, Dr. Rutka, for that fantastic lecture and
Sure enough.
fielding those questions. Much obliged.